So if there's a theme to today's learning set, and I don't think it was intentional, as I said, but it's about work that's being done with and by people most affected by suicide. So that's carers, family, people who live with mental health problems themselves. And so we've got 3 presentations about different ways that work's happening. So the first one, really pleased that we've got Catherine and Deirdre from Norfolk and Suffolk Trust, who are going to talk about their Stepping Back Safely project. And I'll just hand over to you straight away. Thank you.
Thank you, Tom. So we're going to talk about a project we've been doing in Norfolk and Suffolk. We started it off about 2 years ago in Great Yarmouth and Waveney, and it was funded by the First Wave money for NHS England for suicide prevention. Catherine, I can't actually see the presentation very clearly. Is it coming from? Okay, so we want to share the approach that we've developed. We want to provide a progress update and also to gain some critical feedback and hear about some ideas that you might have in other areas that we could incorporate into our project. So our focus was on carer engagement. And that's because we think it might prevent suicide ultimately. So there's the national evidence that's in Lewis's research team provided about when clinicians are interviewed about what could have made a difference. Quite a large proportion of them, I think it was 17 or 18% of them, said that involving family and carers could make a difference. And there's evidence that clinicians think that's good practice to do anyway. But we had our own local evidence because we conducted 2 audits of our local deaths by suicide, one in 2012 to 2016. And that one showed that in our patient deaths, in 10% of cases, or nearly 10% of cases, the service had been contacted by a carer or family member without a corresponding step up in care. So we knew we could do better. And then we conducted a recent audit of our patient deaths by suicide. And we found again that I think it was 9 out of the 60 patient deaths, the recommendation was that family and carers should have been involved more closely. So we had both strong national and local evidence that that might make a difference, which is why we focused on this area.
And some of the additional reasons that we wanted to involve carers was that we know that carers often very much bear the emotional brunt of responding to the risk in their suicidal loved one, and that they deserve our support. And as professionals, we also know that safety can be improved by involving a carer or a family member, and that carers are often left to manage that risk alone at the most vulnerable time, when their loved one is really unwell, particularly out of hours or immediately after discharge. And when safety is decreasing and risk is increasing, we strongly feel that upskilling carers will help them support their loved one, and also help the carer to manage their own well-being. And we also know that the coronavirus pandemic has added to the pressure on carers as access to support services reduced. They're very often the only person in that service user support bubble. So we can also understand that carers might sometimes be in conflict with services about approaches taken as well, and that this conflict can sometimes negatively impact service users also. So our project is very much about increasing collaborative working with service users, with carers and with staff. And we do feel that when carers feel part of the process, it really enables them to build resilience and feel supported. And it also helps reduce that conflict also.
Okay. So I mentioned we're based in Norfolk and Suffolk. We ran the project for 18 months in one clinical area, which was Great Yarmouth and Waveney. And for those of you who don't know the area, it's quite a deprived area. So we were offering it in community services, which provide services for 3,900 adults. It was chosen because it had a higher than average level of suicide, high levels of social deprivation, and there was a strained relationship at the time between the trust and local service user and carer advocacy groups. But it also had staff, service users and carers who were highly committed to changing things and making a difference. So we started off with some focus groups, and they were quite difficult focus groups at the time, but a lot of useful ideas came out of those focus groups about what carers, service users and staff wanted in terms of service improvement.
So, considering what we did with our engagement and our focus groups, we created our project. So we have one element, which is working with those service users. We were asking them what it is that they needed, and they told us that they wanted to be able to step back safely, and they needed help to step back safely. And they also told us that they wanted training, and that they wanted help to staff told us they wanted help with training and how they could engage with carers also. And also when they were facing quite distressed carers, and where carers were alienated from services. So we developed the three training elements to try and identify those needs. So we developed the staff training, we did a carers workshop, and then we did a systemic safety planning intervention, and they're the three interventions that underpin the project that we're doing at the moment. And underlying the principles, so the principles underlying our project are the triangle of care and the recovery approach as well. So the triangle of care, as many of you will know, is a therapeutic relationship between patient, staff members and carers that promotes safety and supports communication and sustains well-being. That was really key to us to consider using the triangle of care, and as a trust we also have a double tick on that triangle of care also.
Yeah, and we wanted to look at recovery approaches to risk as well. So it's understandable that when a loved one feels suicidal, the carer feels incredibly stressed by that, and sometimes the system does as well, the professional system does. But the problem will be sometimes that risk-averse practices in the short term may increase risk in the long term. So initially, we targeted our interventions at those service users who were presenting with repeated risk episodes. And for many of those service users, as the whole system, and that's us included as professionals, became more and more risk averse, their lives kind of shrank, and they didn't have the reasons to live that they needed to go forward. So can we go forward to the next slide, Catherine? Yeah. So we try to focus our approach on recovery principles as well. So 5 dimensions of recovery are connection, hope, identity, meaning and empowerment. So one of the things that we focused on in our interventions was actually managing the risk short term, but trying to ensure that there was enough risk taking that allowed the service user to be developing the life worth living, because many of our service users were feeling very hopeless about the future. They'd maybe one of the things that had escalated risk might have been a loss event of some kind, like a job or a relationship. And sometimes with repeated engagement with mental health services and repeated admission, their whole identity and their lives were becoming dominated by a mental ill health narrative, and they'd lost sight of the kinds of things that would give their life meaning and value.
Okay.
So we have an excellent lead peer support worker in our trust called Amanda Green, and we borrowed some of the ideas that she's put into her safety planning recovery course in our approach as well. But it's she discusses the need to be looked after trap, and that's when risk has been so extreme that other people take over the management of it, and that could be us in hospital using restrictive approaches, or it could be a loved one or a carer as well. So what happens is that that if we start on the right hand of this diagram, is that we develop the belief that others need to manage the risk and take care of the service user, and the service user can't cope themselves. And then the whole system becomes more risk averse, going around the circle. But we undermine the service user's sense of control and agency, and also there's a reduced trust in the service user's capacity to cope, so that when we're back in the situation where the service user is experiencing a suicidal state of mind again, we're back in that anxious position where we maybe are over responding to risk or taking too much responsibility for it. So the next slide. Yeah, so in terms of stepping back safely, if we start on the left-hand side again, and the phrase stepping back safely came from one of our carers workshops, actually. They were the ones that said they needed help to step back safely. So we want to start with a belief that this is a difficult moment, but the service user can get through it and knows what to do in terms of using support and skills. And then we want to consult the safety plan that we've developed, and also soothe and validate and give a bit of hope and make a plan for how to get through. And hopefully, over time, the consequences of that will be that the whole system builds resilience and confidence in the safety plan, and we can continue work on recovery goals and life worth living goals. So that if the service user has a suicidal episode again, it may induce less anxiety, and we can go more into enacting the safety plan together. And this is not to say that we at times wouldn't restrict access to means and things like that, but that we would only do it for a brief period, and that the rest of the time we're trying to focus on long-term goals that will improve that service user's life. Okay.
So as we said, there's 3 basic interventions. So there's the systemic safety planning intervention that Deirdre is going to go into more detail in a moment. There's the carers workshop, and there's the staff training intervention as well. So I'll let you go through the systemic.
So this is a 4-session intervention. It draws on sort of widely available safety planning interventions like that of Barbara Stanley in the States, but also on other therapeutic approaches. So uses a bit of dialectical behaviour therapy in terms of coaching for new skills, and also draws on approaches like behavioural family therapy and other family therapy approaches with schizophrenia in particular, which kind of normalises family communication responses as an emergent property of high stress situations. So we would see our starting point would be to understand that any responses are there for a good reason, and they've evolved out of the high levels of stress that suicide risk places on the whole family or the whole system. Currently, we're delivering this approach with a mental health professional or therapist being the main person who delivers it, but we're looking at ways to make it more accessible and for you not to need to have a high level of therapeutic training to deliver it. So what we do is we gather together, there's a therapist, there's a family member or loved one, there's a service user, and any other involved professionals. That could be a lead care professional or care coordinator. And ideally, we would have someone representing the carer in the room as well. And when Catherine and I have done it together, that's been Catherine, because it's actually useful for the carer to feel that they've got an advocate and someone who naturally aligns with their position on things as well. In terms of inclusion criteria, we've set it as wide as possible, so it can be offered to any service user in secondary care where there's been some suicidality or severe self-harming, and crucially where the service user wants to involve their carer and the carer wants to be involved. So we haven't had anyone say no to it yet. So carers are generally very keen to be involved in the approach. Okay, next slide. So our focus in the safety planning sessions are to create a common understanding of triggers and vulnerability factors, and carers are crucial here because they often notice things that the service user doesn't themselves. We try and have an open conversation about the balance of short-term and long-term consequences of the current approach to risk. We consider obstacles of moving towards a more recovery-oriented risk plan. We try to rebuild relationships if these have been eroded, and increase collaboration and trust in the whole triangle of care as well. We try to increase service user skills, so we coach the service user to think about what skills they can use when they're in a risky state of mind, and we try and develop confidence in the safety plan and hope for the future.
So this is how the plan looks, you know, at the end when we do it. It is a pocket plan that people can keep in their back pocket. They can take a photograph of it and keep it on their phone. They can keep it in their handbag, beside their bed, on the fridge. And it just covers all of those key elements that we discuss within each session as well. So they come away with a comprehensive, enhanced safety plan, but also we're recording that on our recording systems as well.
And there's a workbook alongside
Yes.
that. So we expect service users and carers to look at the workbook between sessions, and we do a lot of kind of psychoeducation about what skills can be helpful, and also there's some exercises for them to do between times. That helps us gauge how engaged they are in the whole process. But mostly people have been really engaged in the whole process. It's been quite surprising compared to other therapeutic interventions I deliver, really, but it's been a lot of engagement in this. So in terms of what we've observed as a result of delivering the systemic safety planning, and that's systemic with a small s, just because it involves a whole system, it's not alluding to any kind of systemic family therapy or anything like that, is we find that people end up with a much more personalised safety plan and with increased understanding of what can lead to a risky episode. There's increased skills use and self-management by the service user and increased confidence in this by everyone. There's use of help and support in such a way that long-term risk is not increased. So we're not saying to service users that they shouldn't reach out for help and support, but we have a conversation with the service users and care about how to reach out for support and when is help helpful. There's a shared understanding of the recovery approach and more movement generally towards a life worth living. There's increased hope and a decreased sense of entrapment or defeat. So we're working on this in our safety plan. You may not have noticed, but in the bottom corner we have cheerleading statements, but they can also be statements of hope and statements around there will be a way forward. So we try and elicit those kinds of hopeful statements within the safety plan as well. And sometimes we identify areas for further intervention. So as I mentioned, we don't have any exclusion criteria. We don't exclude by diagnosis or anything else. So sometimes something will come up in the course of a safety plan, like how central someone hearing voices might be to their risk, and actually they may need a further intervention. And certainly for some carers, what comes up is their life has become dominated by their loved one's risk and they need something themselves, in which case we can signpost them towards an intervention for themselves, or they can take part in another element of our program, which is the carers workshop, which I'll hand over to Catherine.
Okay, so the carers workshop, prior to lockdown and COVID, it was a one-day workshop for carers only. They told us in our focus groups that they needed it just for them. So we concentrate on just inviting them. And again, it's called Stepping Back Safely. We are now in the process of developing those workshops to go online, and also workbooks that will go along with those as well. I mean, our hope is to get back into the classroom, but at this moment in time, online is how we're going to deliver it in the short term. And it was developed from the focus group we held with the service users and their carers about what carers wanted to say and wanted to be involved in. Carers told us that they hated the term positive risk taking. So they came up, as Deirdre said, with the phrase stepping back safely, and that's why we called it that. And it does explore the impact of their loved one's risk on the carer, and it acknowledges the impact this has on the carer as well. So we do a lot of validation within the carers workshop as well. And they develop a personal plan on how to participate, how participants can reduce their emotional reactivity in situations of risk. And it encourages participation to increase their the carers' emotional resilience by reconnecting with things that gave their lives meaning and value as well. So their identities are not wholly bound up with their loved one's mental ill health. And it does look at supporting styles, so caring and supporting styles, and how they've adapted these in relation to their loved ones, and also looks at the pros and cons of this as well. And it gets participants to really think about how they might want to shift their supporting style. So that's kind of what the carers workshop is all about. And we are using some DBT, dialectical behavioural tools within those workshops as well, and also considering solution focused approaches as well. So then the staff training, I'll hand back over to you, Deirdre.
Yeah, so the staff felt these were very difficult conversations to have with carers often. Sometimes carers had become estranged from staff, or staff had felt that the service user had not wanted to involve their carer, or the service user may even have stated that. So we do now a little bit of training for staff around how to encourage the service user to involve their carer, explaining that we think that it will increase their safety in the long term. And also how to have these difficult conversations, because they are sometimes incredibly emotive conversations. Obviously, it's around an incredibly emotive area. So how to feel more confident about having those conversations with carers as well, and understanding a bit more about the carer perspective on risk, so that we come back together as a triangle and aren't kind of fractured elements within that person's care. So where we're up to now is we've got another 2 years of funding which has been provided from within our trust. So we were having money from NHS England, but now we've got some money from within the trust, and we are with the safety planning intervention, we've got the workbook and the safety plan developed, and we're currently working on a clinician manual, clinician training and information leaflets for service users and their carers are in progress. And we're rolling this out currently in 2 community areas, outpatient community mental health teams at the moment, and then we're going to move on to 2 inpatient areas within the next 2 months. With the workshop for carers, the workshop we have developed it. It's suitable for online work, but we're revising it in response to our own observations and also feedback from participants. And we're hopefully forming a working group for co-production and potential co-delivery, both locally with interested parties, but also nationally, because we presented at the NSPA and we got some very interested parties there who've been in the position of caring for someone who feels suicidal. And with the staff training, we were originally providing that as a freestanding thing, but we're going to try and roll it into our existing mandatory training, because there's a huge burden on our staff for training at the moment. We're not going to get that much sign up, so we are going to roll it in to our mandatory training, and Catherine's taking a lead on that because she's also one of our primary trainers for care planning and Dialogue Plus. So we're trying to see ways to get it in within the mandatory training. Originally, we started with people who'd presented multiple times feeling suicidal or with severe self-harm, but we're thinking also of how to adapt it to other settings, for example, primary care. In our area, we're starting to have primary care mental health networks, and we know that a lot of people who feel suicidal don't get into our service. Actually, they present to their GP in a crisis, and actually this is a brief intervention that we could possibly provide in primary care as well. So we're looking at that as a possibility.
Okay, so as Deirdre said, we now have funding to take this across the trust for the next 2 years. And the board have also approved and given us the opportunity to work with external organisations and share the work, share the materials, share the processes and the design of all 3 of the interventions. And from the NSP, National Suicide Prevention Alliance conference, we've had a big number of organisations contact us. So we're going to have a focus group with them next Monday, and to look at the best ways to take that forward and agree how we're going to work with them. So very interested. If anybody else is interested, just please do contact us and let us know. And
yeah, so we're happy to share anything, but we're also happy to borrow heavily. We are inveterate borrowers, so if you've got something similar going on in your area or things you can share, we'd be very happy to receive other similar interventions or practices. That's it, apart from over to questions, really.
Thank you so much to both of you. It's really interesting, really well, I thought it was really good work as well. There's a couple of questions in the chat. I'm just going to put those to you, and then if anyone wants to, as you said, you'd love to borrow from other people or steal their work, and that's what we encourage as well. So if anyone else wants to think of that, while we just do these couple of questions. So Adele Owen has asked about whether this is focus on carers of adults, or is it also looking at cares for younger people? And I suppose the implicit question is, if it's just adults, have you got any plans to expand out into children and young people as well?
Yeah, one of our implementation sites is our local youth team. So it's currently the Norfolk youth team, which is Norfolk wide. When we go into a new setting, like we're starting in the inpatient areas soon, we're going to try and adapt the approach, because we recognise there's going to be adaptations of the approach for young people. Young people, most of the young people who are in contact with our services and our youth teams in particular are still living at home, even more so during the pandemic. They do have involved carers and things, but they may have, as I would have done at their age, slightly ambivalent feelings about fully involving their carers in their care. So there'll be different challenges in that area, but we have interested clinicians in those areas who are willing to work with us on the adaptation and use their knowledge, obviously, if they're working with that age group.
Thank you. That's really interesting. I think there are probably quite a few people listening who'd like to learn more from you, and they've kind of put that in the chat. Perhaps it's always helpful when we can make connections through these sessions. Just one more question about this is from Tess, and she's asked about what the main outcomes for patients and carers and staff were that you've evaluated.
We made the mistake of collecting too much data, and as a result it didn't have good reportable outcomes. So we've learned from that. We're going to make it a lot more simple. I suppose what we saw was, but these are our subjective outcomes. With the carers workshop, people felt that they were actually listened to and validated, sometimes for the first time by the trust. They also felt relieved that they could be allowed. I think once you get kind of drawn into that the caring dynamic, you do lose sight of your own needs and things, and they felt relieved to be given permission to connect with the things that gave their own lives meaning and value as well. And also it had different outcomes for different people. So some people would tweak their caring role to be slightly less involved, and some people had stepped forward and actually wanted to be more involved. So it has different outcomes depending on and we want to capture that. We've developed now just a 5-item questionnaire focused on CHIME principles to capture our recovery this time around, rather than endless questionnaires where we got lots of data and no results. It's not a big dose of anything, so you can usually measure outcomes when people get a big dose. We don't expect attending a one-day workshop to be life-changing, but we do want it to create meaningful shifts for people. And with the service users, what we found is they did feel more confident about their plan. It nudged the service user towards self-management of their risk. We had very open conversations. The carer usually felt less burdened. The service user felt less burdening, which was also crucial because that's a risk factor for suicide. There was an agreement about how to use support, and everybody felt that, and a shift towards the way support was being used to be seen as helpful and not intrusive, or not creating a sort of unhelpful risk averse kind of approach. So we're convinced by the approach. We just need to measure its outcomes now.
That's great, thank you. Still a couple more things in the chat, but as before, I think we need to probably move on to the next item.
We'll have a look at those and answer what we can, and then take details as well to come back to them.
And people are welcome to contact us as well. They'll have our email on the original list. They're welcome to contact us outside this meeting.
That's great. Well, thank you so much for sharing that.